Good afternoon. My name is Serena Wong, and I'm a medical oncologist in the breast medicine service at Memorial Sloan Kettering Cancer Center. The title of my talk today is Estrogen Receptor Positive Metastatic Breast Cancer Treatment Updates. Estrogen receptor positive metastatic breast cancer certainly impacts a very large number of women in the US. And to give you an idea of the scope of what we're dealing with, in 2019, it was estimated that approximately 270,000 new cases of breast cancer were diagnosed in the US. And between 5 to 10% of women present with metastatic disease at the time of initial diagnosis. Up to 30% of women originally diagnosed with early stage breast cancer will unfortunately go on to develop recurrent metastatic breast cancer. Approximately 2/3 to 3/4 of all breast cancers are estrogen receptor positive. And endocrine therapy is the cornerstone of treatment for advanced ER positive metastatic breast cancer in both pre and postmenopausal patients. However, not all advanced ER positive breast cancers respond to endocrine therapy, and many that do respond eventually relapse. So new approaches are clearly needed to improve efficacy of endocrine therapy and to delay the onset of resistance. The treatment landscape of ER-positive metastatic breast cancer has evolved significantly over the past 5 decades. In the 1970s, tamoxifen was developed, and this was followed later in the 1990s by the aromatase inhibitors. In the early 2000s, fulvestrant, which is a selective estrogen receptor degrader, entered into the realm of endocrine therapies. Then in the past 8 years, there has been the rapid development of a number of targeted therapies that have been approved for use in conjunction with endocrine therapies and have allowed us to make ongoing improvements in the treatment of ER-positive breast cancer. And we'll talk about each of these separately. Now, in order to understand the treatment of ER-positive metastatic breast cancer, we need to first understand the role of the estrogen receptor in the breast cancer cell. In ER-positive breast cancer cells, estradiol binds to the estrogen receptor. The complex then travels into the nucleus where it attaches to the DNA and turns on certain target genes, leading to cell growth and proliferation. There are a number of ways that we can target the estrogen receptor pathway to interfere with cancer cell growth and survival. Tamoxifen attaches to the estrogen receptor and blocks estrogen from attaching to the receptor. This prevents the activation of target genes and results in the slowing down or cessation of growth of the cancer cell. Another way we can interfere with the ER pathway is by decreasing the production of estrogen. In a postmenopausal woman, the main source of estrogen is in the fat tissue, where the male sex hormones androstenedione and testosterone are converted to estradiol by an enzyme called aromatase. We can block this conversion using aromatase inhibitors. This approach, however, is only effective in the postmenopausal setting because in premenopausal women, the ovaries are still producing a significant amount of estrogen. A third approach to targeting the ER pathway is by using a selective estrogen receptor degrader. Degradation of the estrogen receptor can prevent activation of the genes involved in cell growth and survival. So this table summarizes the various endocrine therapies that we use for ER-positive breast cancer. And actually, the very first person to pioneer endocrine therapy for the treatment of breast cancer was a man named Sir George Beatson. He was actually a physician in Scotland who in the late 1800s published a paper detailing the regression of advanced breast cancer in 2 out of 3 women in whom he had performed an oophorectomy or surgical removal of the ovaries. Now, at that time, estrogen had not even yet been discovered. But because of his work, oophorectomy became the standard treatment for breast cancer over the ensuing years. Of course, this approach is only effective in premenopausal women, since after menopause, the ovaries no longer produce estrogen. And nowadays, we don't actually have to physically remove the ovaries. We can actually achieve the same effect by using injections to chemically shut down the ovaries. So these are medications such as goserelin, leuprolide, or triptorelin. The selective estrogen receptor modulators include drugs such as tamoxifen, toremifene, or raloxifene. The aromatase inhibitors include anastrozole, letrozole, and exemestane. Currently, there is only one FDA-approved ER downregulator or degrader, and that is a drug called fulvestrant. Now, unfortunately, about 30% of hormone receptor positive metastatic breast cancers are de novo resistant to endocrine therapies, with most developing acquired resistance. There are multiple mechanisms of resistance, and these include things such as deregulation of the estrogen receptor itself. There can be activation of signaling pathways, such as the PI3 kinase AKT-mTOR pathway, which we'll talk about in a little bit. And there can be upregulation of the cell cycle pathways, such as CDK4/6 pathways. And this latter one is what I want to touch on first. So going back just very briefly to high school biology, if you remember that all cells cycle through phases of growth, including DNA replication and cell division as well. Each phase of the cell cycle is tightly regulated by brake mechanisms. And this is very important because without these brakes, the cells would grow and divide uncontrollably. Now, growth of the ER-positive metastatic breast cancer is dependent on a protein called cyclin D1, which is a direct transcriptional target of the estrogen receptor. Cyclin D1 activates CDK4 and CDK6, and this results in transition of the cell from G1 to S phase and then subsequent entry into the cell cycle. Inhibiting CDK4/6 prevents cell cycle progression and can slow down cell growth. And when combined with endocrine therapy, inhibiting CDK4/6 can actually cause cancer cell death. This approach has actually been extremely successful, and in recent years, there has been the development and subsequent approval of 3 CDK4/6 inhibitors, which have dramatically improved outcomes for patients with ER-positive metastatic breast cancer. The first drug that was approved in this class is called palbociclib, also called Ibrance. Back in 2015, this drug received accelerated approval. It was approved in the first-line setting with letrozole in postmenopausal women. And what I mean by first line is the first therapy that a patient starts on when they are first diagnosed with metastatic breast cancer. The following year, palbociclib was approved in the second-line setting with fulvestrant. In 2017, with the larger confirmatory trials demonstrating that essentially confirming the benefit of this drug, regular approval was given with an aromatase inhibitor. And then in 2019, the approval was expanded to also include men. The second drug in this class to gain approval was ribociclib, also called Kisqali. This was approved in 2017 as first-line therapy with an aromatase inhibitor in postmenopausal women. And in the following year, it was given approval for first-line therapy with an aromatase inhibitor in pre- and perimenopausal women. In addition, it was given approval with fulvestrant in both the first-line and second-line settings. The third drug in this class is called Abemaciclib, also known as Verzenio. This drug received approval in 2017, initially in the second-line setting with fulvestrant. It also received approval as a single agent or as monotherapy in patients previously treated with chemotherapy for metastatic breast cancer. And then subsequently, it received approval in the first-line setting with an aromatase inhibitor. All 3 drugs are actually remarkably similar to each other and are often used interchangeably. So sometimes if I have a patient who has a side effect with one, I have a very low threshold to switch them to another one. Now, what exactly is the impact of the CDK4/6 inhibitors? In the first-line setting, these were 5 studies that all compared standard endocrine therapy alone or with the addition of a CDK4/6 inhibitor. And all of these trials were remarkably similar to each other. By adding a CDK4/6 inhibitor, there is near nearly a doubling of what we call progression-free survival. That is the amount of time that the cancer remains under control without growing. Similarly, in the second-line setting, we again saw a significant improvement in progression-free survival with the addition of this class of drugs. So all of these were positive trials. Now, what about some differences among the three CDK4/6 inhibitors? So I generally consider palbociclib and ribociclib to be a little bit more similar to each other compared to abemaciclib. Each of these drugs is dosed once daily for 3 weeks on and 1 week off, whereas abemaciclib is a drug that is given twice daily continuously. With palbociclib, we tend to see a little bit more neutropenia or low white blood cells. We can also see low platelet counts, and because of that, it's important to monitor blood counts. With ribociclib, we also see a decrease in blood counts. In addition, ribociclib can cause something called QT prolongation, which is an electrical disturbance that can be seen on an EKG. And if not monitored closely, can potentially lead to an abnormal heart rhythm. So it's important to incorporate EKG monitoring, particularly within the first couple of months of initiating this drug. With abemaciclib, we can again see a decrease in blood counts, although it tends to be less profound compared with the other two drugs. However, what we do see more frequently are GI side effects, in particular diarrhea. There also tends to be a little bit more fatigue associated with abemaciclib. And again, we need to monitor blood counts. With these drugs, sometimes we can also see an elevation in liver function tests, so that's also an important parameter to monitor. Abemaciclib has also been studied by itself as a single agent in ER-positive, HER2-negative metastatic breast cancer. And in this study, this population that enrolled had rather resistant disease, as they had to have progressed on prior endocrine therapy, and they had to have received at least 1 or 2 lines of chemotherapy in order to be eligible to participate in this trial. And in this difficult to treat population, there was a clinical benefit rate of about 40%. And what I mean by clinical benefit rate is either a decrease in tumor size or stable disease for at least 6 months. So this is what led to the approval of abemaciclib as a single agent. The other two CDK4/6 inhibitors are not approved for use alone. They're approved in conjunction with endocrine therapy. Another unique aspect about abemaciclib is its apparent activity in the brain. This was a small study looking at abemaciclib in patients with brain metastases. Patients who enrolled on this trial had to have had at least one brain metastasis that was either new or that had not been irradiated previously. And while they didn't see significant shrinkage in the brain lesions, about 25% of the patients had stabilization of their brain metastases for at least 6 months. I think these results are rather meaningful in a population that often has a somewhat poorer prognosis and for whom there are a limited number of treatment options. So the next step is to examine novel combinations with abemaciclib in order to continue to improve response rates for our patients who have metastatic ER-positive breast cancer with brain metastases. Now, I just showed you data on the improvement in progression-free survival with the addition of CDK4/6 inhibitors. But ultimately, what we want to know for our treatments is, do they ultimately translate into an improvement in overall survival for our patients? And the short answer to this is yes, they do. In the MONALEESA-3 trial, fulvestrant was added to ribociclib in the first and second line setting. And what they showed was that there was, in fact, an improvement in overall survival. In the MONARCH 2 study, this looked at fulvestrant with or without abemaciclib. And again, with the combination arm, they saw about a 9-month improvement in overall survival. The PALOMA-3 study looked at palbociclib in combination with fulvestrant. And for the overall population in this study, there was a suggestion of an overall survival benefit, but it did not reach statistical significance. Now, the populations in all three of these trials were slightly different, and potentially the reason we didn't see a robust overall survival benefit in this study was because there may have been a slightly more endocrine resistant population. But when they broke the data down and looked at endocrine sensitive tumors versus endocrine insensitive, it did appear that there was a survival benefit in the population that was more endocrine sensitive. One of the big questions that remains unanswered is whether we should be continuing CDK4/6 inhibition and perhaps switch the endocrine partner after a cancer has progressed on a CDK4/6 inhibitor. There are many trials that are ongoing to try to address this question, and this table just shows 3 of them. Currently, outside of a clinical trial setting, we generally do not continue this agent if the cancer has progressed on it. So that's all we're going to say right now about the cell cycle and the role of CDK4/6 inhibitors. I want to move on to another mechanism of resistance to endocrine therapy, and that is the activation of a signaling pathway known as the PI3 kinase AKT-mTOR pathway. So this is an important pathway that regulates cell survival and proliferation. And in ER-positive breast cancer, it can frequently be altered. And that can lead to resistance to endocrine therapies. We think that simultaneous dual targeting of both the ER pathway and the PI3K AKT-mTOR pathway can be very important. The Bolero-2 study was a study that was conducted several years ago and looked at the role of this dual blockade with blocking both pathways. This looked at a drug called exemestane, which is an aromatase inhibitor, in combination with an mTOR inhibitor called everolimus, also known as Afinitor. And this was in a population that had had progression on prior endocrine therapy. They were randomized to exemestane alone or to exemestane plus everolimus. And what the data showed from this trial was that there was, in fact, improved disease control with the combination compared to exemestane alone, with a progression-free survival improvement of 4 months to 11 months. There were, however, significant side effects that were seen with the addition of everolimus. We did see quite a bit of mucositis or mouth sores. There was fatigue, and there was also some significant diarrhea. However, with more experience with this drug, we've actually found that we can pretty well prevent and control these side effects. So with the results of this trial, this was the first indication that targeting the PI3 kinase pathway actually works. And we did this by blocking mTOR, which is downstream of the PI3 kinase protein. Based on the results of this trial, everolimus was approved for second-line therapy. Interestingly, everolimus did have the same benefit whether or not a mutation was present in the gene that encodes for PI3 kinase. Now, what about targeting PI3 kinase itself? About 40% of ER-positive breast cancers have a PIK3CA mutation, and this results in the hyperactivation of the PI3K pathway. PIK3CA is a gene that actually encodes the instructions for making a subunit of the enzyme PI3K. And PI3K signaling promotes estrogen-independent growth of ER-positive breast cancer cells. And this growth is inhibited by the addition of PI3K inhibitors to the anti-estrogens. There are different isoforms of the PI3K protein. Targeting the alpha isoform has been the most successful approach in the treatment of cancers that have a PIK3CA mutation. It turns out that when we tried to inhibit the other isoforms, we saw some very severe side effects and realized that that approach was likely not going to be feasible. In a pilot trial of alpelisib, which is a PI3 kinase inhibitor, in combination with fulvestrant, we saw a 9-month progression-free survival in a population that was very heavily pretreated and that had the PIK3CA mutation. So this then set the stage for a larger phase 3 trial called the SOLAR-1 trial. This was a randomized, double-blind, placebo-controlled phase 3 trial that enrolled patients with ER-positive, HER2-negative metastatic breast cancer who had recurrence or progression on or after an aromatase inhibitor. This trial enrolled patients who either had or did not have a PIK3CA mutation, and patients were randomized to receive either fulvestrant with placebo or fulvestrant in combination with alpelisib. And what they saw was that in the PIK3CA mutant cohort, there was an improvement in progression-free survival from 5.7 months to 11 months. There was no benefit seen in the group of patients whose cancers did not have the PIK3CA mutation. So based on the results of the SOLAR-1 trial, alpelisib was approved for the treatment of ER-positive metastatic breast cancer that harbors a PIK3CA mutation. There are some unique side effects of alpelisib. We did see some severe hyperglycemia or increases in blood sugars, 37% in patients who received alpelisib plus fulvestrant versus only 0.7% in the placebo and fulvestrant arm. We also saw about a 10% incidence of severe rash and a 7% incidence of severe diarrhea. Interestingly, the hyperglycemia and rash typically occurred during the first 2 weeks of therapy, whereas diarrhea could have occurred during any time of therapy. About 25% of patients in this trial actually discontinued alpelisib due to potential side effects. 6% actually discontinued for hyperglycemia, and 3% discontinued for rash. In contrast, no patients in the placebo fulvestrant arm discontinued therapy either for hyperglycemia or rash. Due to the high incidence of rash and hyperglycemia that we saw with this drug, we are now very mindful of implementing certain measures at the time of initiating alpelisib. We've learned that starting an antihistamine can decrease the incidence and severity of the rash. It's also important to check a baseline fasting glucose and a hemoglobin A1C. In patients who are either pre-diabetic or diabetic, we really want to optimize blood glucose prior to starting this drug. And during treatment, especially during the first month of therapy, frequent monitoring of glucose levels is actually very important. GDC-006 is another PI3 kinase alpha inhibitor that is currently being studied. This drug is a 300-fold more selective for the alpha isoform compared to the other isoforms, with about a 4.5-fold greater selectivity for the mutant versus non-mutant form. And our hope is that because of this, it will be much more effective and also have fewer side effects, and especially less GI side effects. This is a study looking at GDC-0077 in the first-line setting as part of a triple drug combination with fulvestrant and palbociclib in ER-positive metastatic breast cancer with a PIK3CA mutation. In this study, patients are randomized to receive fulvestrant plus palbociclib, which is a current standard of care, versus fulvestrant plus palbociclib plus GDC-0077. So we await results of the study. There is also some work looking at the role of AKT inhibitors. So AKT is just downstream of PI3K in that pathway. There is a drug in development called capivasertib, which is an AKT inhibitor. In the FACTION trial, this was a randomized phase 2 study of capivasertib plus fulvestrant versus placebo plus fulvestrant. And these were postmenopausal women who had relapsed or progression on an aromatase inhibitor. And they did see an improvement in progression-free survival from 4.8 months to 10.3 months. There was also a suggestion of an improvement in overall survival. The progression-free survival benefits appeared to be observed regardless of whether or not there was a mutation in that pathway. About 1/3 of patients who received the study drug did require dose reductions, primarily due to diarrhea and rash. There is currently a larger confirmatory phase 3 trial that is enrolling patients. So in summary, the addition of everolimus to exemestane results in a significant improvement in progression-free survival and can be a standard option in patients who progress on a CDK4/6 inhibitor. PI3K inhibition with alpelisib results in improvements in overall response rates and progression-free survival, and is now FDA approved for PIK3CA mutant ER-positive metastatic breast cancer. The activity of AKT inhibitors with endocrine therapy appears promising based on phase 2 data, and we now await results from the larger registrational trials. Now moving on to mutations in the estrogen receptor. Mutations in the estrogen receptor while on aromatase inhibitor therapy can lead to resistance to this class of drugs. ESR1 mutations are common in patients who have progression on an aromatase inhibitor, and when present, they appear to be associated with worse outcomes. About 30 to 50% of patients who have progression on an AI have an ESR1 mutation in the metastatic setting. So this is an interesting trial. This is called the PADA-1 trial. This trial enrolled patients who were getting upfront endocrine therapy with an aromatase inhibitor in combination with palbociclib. And investigators took serial collections of circulating tumor DNA from each patient. And the goal was to determine how many patients at baseline had a mutation in ESR1, who then acquired the mutation during therapy, and then potentially who reverted back to wild type or a non-mutant ESR1 during therapy. And what they found was that the ESR mutation was actually rare in those with early progression, but then became a major mechanism of resistance after 6 months. Now, the second part of the study then took patients who acquired the ESR mutation and then randomized them to either continue with the aromatase inhibitor and palbociclib, or to switch them to fulvestrant plus palbociclib. We don't yet have data on the randomized portion of this trial yet, but in the upfront portion, they found that the rate of ESR mutations at baseline was low, about 3%. But patients who had these mutations actually had worse outcomes with an aromatase inhibitor and palbociclib compared to patients who did not have this mutation, with a difference in progression-free survival of 11 months versus 26.7 months. But then, very interestingly, at 4 weeks on treatment, 22 of the 33 patients who at baseline had this ESR1 mutation then cleared that mutation with the addition of palbociclib. And if they cleared the mutation, they actually did better than if they had maintained the mutation. So this is certainly very interesting data. We still have to await the second portion of the study to find out where this then brings us. Now, what about targeting ESR1 mutations with selective estrogen receptor degraders? So the SERDs inhibit cancers through degradation of the estrogen receptor on the outside and the inside of the breast cancer cell. This degradation can prevent activation of genes involved in cancer cell growth and survival. We think that these may have greater activity than the aromatase inhibitors in resistant cancers that harbor the ESR1 mutation. Currently, the only FDA-approved SERD is fulvestrant, which is in fact a very potent ER degrader, but unfortunately, because of poor bioavailability, its efficacy may be limited. We think that oral agents may in fact have greater availability and activity in the setting of endocrine resistance. There are currently many oral SERDs that are in clinical investigation, and probably the one that is the most far along in development is a drug called elacestrant. In a pilot study, with this drug, they observed a clinical benefit rate of about 40% in heavily pretreated patients. And so that has set the tone for a larger phase 3 study. This is called the Emerald study. In this study, postmenopausal men and women with ER-positive, HER2-negative breast cancer that has progressed on at least 1 or 2 lines of endocrine therapy are enrolled. Patients can have received up to 1 line of prior chemotherapy, and they had to have had documented progression on a prior CDK4/6 inhibitor. And patients are randomized to endocrine therapy alone with either fulvestrant or an aromatase inhibitor or elacestrant. So this trial is currently accruing patients. Now, switching gears a little bit, I want to talk about a class of drugs called antibody-drug conjugates. And this is moving away from the ER pathway and away from the cell signaling pathways that we've been focusing on thus far. This is a little bit more in the realm of chemotherapy. So antibody-drug conjugates are a relatively novel and intelligent way of delivering therapy to tumors. They consist of an antibody that targets a specific tumor antigen that is abundant in tumors but minimal in healthy tissues. And this allows the drug to discriminate between cancerous and normal tissue. The antibody is linked to a chemotherapy drug, what we call the payload, by a linker that is stable in plasma but then dissolves once it enters the cancer cell. And once released within the cell, it then causes cell death. So this is a way of delivering very potent drugs directly to the cancer cells with relative sparing of normal cells. Sacituzumab govitecan is a drug that has in recent years garnered a lot of excitement in the treatment of triple-negative breast cancer, and earlier this year was granted accelerated approval by the FDA in metastatic triple-negative breast cancer after progression on at least 2 prior therapies. We're now looking to see whether or not it may also play a role in the treatment of ER-positive metastatic breast cancer. Sacituzumab govitecan consists of an antibody that targets TROP2. This is a protein that is highly expressed in many cancers, including breast cancer. So this TROP2-directed antibody is linked to SN38, which is the active metabolite of a chemotherapy called irinotecan. The linker is designed to dissolve in a low pH environment, such as the tumor microenvironment. And this leads to the rapid release of the payload inside the tumor. In addition, however, there is something called the bystander effect, in which SN38 also diffuses into neighboring cells that may be TROP2 negative. As I mentioned, this has turned out to be very active in the treatment of triple-negative breast cancer, and we have seen responses in situations where there has been progression on multiple prior chemotherapies. And we're now looking to see whether or not we can expand the use of this drug. In this phase 2 study, sacituzumab govitecan was given to patients who had hormone receptor positive HER2-negative breast cancer. It was a relatively smaller study, 54 patients. These were patients who had received quite a bit of prior treatment. The median number of prior therapies for metastatic breast cancer for patients enrolled in this trial was 5, and the median number of prior chemotherapies for metastatic breast cancer was 2. And what they saw was a clinical benefit rate of about 48%. There were some side effects associated with this drug. We did see quite a bit of neutropenia. We also saw diarrhea, although the rates of severe diarrhea were quite low. We also saw some nausea and vomiting, but again, the rates of severe nausea and vomiting were only on the order of 2 to 5%. So based on the activity seen in this study, there is now a larger phase 3 trial that is ongoing called TROPiCS-2. This is a randomized trial looking at sacituzumab govitecan versus standard chemotherapy in ER-positive metastatic breast cancer. Another antibody-drug conjugate that we're evaluating for ER-positive HER2-negative breast cancer is trastuzumab deruxtecan, or Enhertu. This drug was actually approved in 2019 for the treatment of HER2-positive metastatic breast cancer. The antibody in this case binds to the HER2 protein on the surface of breast cancer cells, and the payload that it's linked to is called DXD. This antibody-drug conjugate also demonstrates a bystander effect, meaning that the payload can also kill adjacent tumor cells, including neighboring HER2-negative cells. This was a pilot study looking at the role of trastuzumab deruxtecan in cancers that have low levels of the HER2 protein. And the way that this was measured was by a method called immunohistochemistry. In order to be considered HER2 low, the tumor had to have had an IHC score of 1+ or 2+, and there could not have been any gene amplification of HER2 detected by fluorescence in situ hybridization. And interestingly, it appeared that this agent did in fact have some activity in cancers that had low levels of HER2 protein. There is now a larger phase 3 trial that is ongoing to see if we can confirm these findings. This is the DESTINY-04 trial, a randomized open label phase 3 study. This is enrolling patients with HER2 low metastatic breast cancer with progression on endocrine therapy. They cannot have received any prior anti-HER2 treatment, and patients are randomized to standard chemotherapy or to trastuzumab deruxtecan. So we eagerly await the results of this trial as well. My last few slides are about immunotherapy, and I wanted to include this because I frequently get questions from my patients about immunotherapy for the treatment of their breast cancer. Now, immunotherapy has been a game changer for multiple different types of cancers. However, we're still trying to figure out whether there is, in fact, a role for it within the realm of ER-positive, HER2-negative metastatic breast cancer. I'm not going to go into too much detail about this, but there are preclinical laboratory data demonstrating that CDK4/6 inhibition may synergize with immunotherapy. It can promote T-cell activation and infiltration into tumors, and it can also enhance efficiency of tumor cell antigen presentation. What we see here in this graph is that in the laboratory, when abemaciclib is combined with immunotherapy, there is a more significant reduction in tumor volume. So the flatter the curve, the more cell death that they saw. Of course, what we observe in the lab does not always translate into what we see in humans, and therefore we do need to conduct clinical trials. This is the phase 2 PACE trial. This is a study looking at continuing palbociclib after prior progression on a CDK4/6 inhibitor. And patients are randomized to one of 3 arms. In arm 1, patients receive fulvestrant alone after progression on an aromatase inhibitor and a CDK4/6 inhibitor. If they progress on fulvestrant, there is then a crossover built in for them to initiate palbociclib at the time of progression. Arm B is looking at the combination of fulvestrant and continuing the CDK4/6 inhibitor palbociclib. And then arm C is looking at the addition of a drug called avelumab, which is a type of immunotherapy. And this is in addition to fulvestrant and palbociclib. So it will be interesting to see whether the addition of avelumab confers additional benefit beyond just fulvestrant and palbociclib. So, in conclusion, the addition of the CDK4/6 inhibitors to endocrine therapy improves progression-free survival and overall survival in ER-positive metastatic breast cancer. For patients with tumors that harbor a PIK3CA mutation, fulvestrant plus alpelisib is associated with improved progression-free survival compared to fulvestrant alone. Adding everolimus to endocrine therapy improves disease control regardless of PIK3CA status. AKT inhibitors appear to be promising regardless of the pathway status of PI3K, AKT, mTOR. ESR1 mutations may be acquired and confer resistance to endocrine therapy. The oral SERDs lead to degradation of mutant and non-mutant ESR1, regardless of pathways activating the estrogen receptor, and many are under development currently. Antibody-drug conjugates deliver high levels of very potent novel cytotoxic agents to tumor cells and show promise in the treatment of ER-positive metastatic breast cancer. Understanding resistance mechanisms will allow us to direct choice of therapy and develop new agents in a rational fashion. Thank you very much for your attention.